Well, there's a risk that hasn't been addressed up till now, but now that we're actively doing our own intervention in a new population, some of whom are less than middle class, living in dangerous neighborhoods, and I've heard this in Georgia also, that there are risks to the person going to the home.
Right.
In addition to the expense, which is
Right.
a reason not to do it, there is the risk, and we're really now suddenly concerning ourselves with managing the risk for the person, the treatment, who wants to provide the treatment in the home, and how do we keep them safe?
Right.
I'll just add a quick comment, but earlier I mentioned that orientation process that's so important to do with that agency. One is it does address those issues of risk for the interventionist going into the home, but it also addresses that referral process and what is appropriate when you do run into a situation of risk like that. And last, I would say, as far as the risk identification, I think it's critical. It's not that the interventionist identifies it alone. It's that you do it in tandem with, in collaboration with the home, whoever's in the home, whether it's a family there or a spouse, caregiver, whatever. It's done together with them, not for them.
I actually would like to add something in terms of risk. So, well, we have this wonderful finding that we postpone nursing home placement for a year and a half. And so often the people who are adopting the intervention think that the goal is to stop people from placing their relatives in nursing homes. And then they feel like they've failed if the person does go into a nursing home. And so I've learned to start out the training by saying that in our very first paper, which we published many, many years ago, when we had looked at the differences between the first 100 people in each group who had gone through at least a year of the intervention, of the 11 people who placed in the treatment group, 8 of them placed their relatives because the counselor saw that either the person with dementia or the caregiver was at risk. So if you go in with this goal that you're going to prevent institutionalization, or whatever the goal is, it has to be understood that the goal is really to improve the well-being of everybody. And maybe the living environment is too risky for the people who live there.
If I do want to talk, add to Mary's point, which may not be, Alan, what you meant in terms of risk, but it is underestimated the risk of the person going into the home, which is an issue that when you're doing anything in the home should be attended to. And I think that the VA, I've really learned a lot from the VA's home approach, and they do view every home as a contaminated setting and then proceed that way. And so we spend a lot of time training our interviewers and our interventionists in research. I have been also surprised that home care agencies don't necessarily have those protocols in place, and that we're trying to really reach out to low income, all different kinds of neighborhoods and places, and you really do need to spend time. And also, when you go in the home, you can encounter so many different other risk situations that you do have to train everybody in terms of when to call adult day protective services, when to involve others in the care. It just opens up. It's another whole aspect of what your protocol has to look like.
And I think we've done the same. We're actually forming a relationship with adult protective services, and we found them to be extremely helpful to caregivers, and caregivers as a whole incredibly thankful that we were able to get them involved.
Yes.
And making that feedback loop back to primary care providers has been helpful for their long-term health as well.
And I just have to say one more thing. When you go into someone's home, you'd be surprised. Well, it can be very surprising the environmental conditions that people are living under. And that's another piece where we have had to partner with home repair services, because people are literally living with big holes in the roof, or their back door doesn't close and they have tarps. I mean, this is and they're providing care. And so, if the delivery is in the home, you have to attend to these factors.
And that's the primary reason we involve adult protective services, is due to the living conditions.
Yeah.
Okay, I think we have another question.
It's a statement
question. So I'd like to just raise the issue of ethnic diversity in the delivery of these evidence-based programs. And speaking as a provider in the community who has translated a lot of these programs, it's very the challenges are really great when you're working with taking them programs that are developed in mainstream communities that are middle class and have decent education levels and bringing them to other communities with both the complication of maybe low health literacy and the complication of culture. And so as you look, we've looked at Savvy Caregiver and looked at how to change that into something called Cuidando con Respecto, which is interactive and much less verbal and much less written, and it's interesting, and we need that for all of these programs as well. I also think of NYU Caregiver Intervention, which is really interesting. So if you take it into a Japanese community and and consensus and harmony is highly stressed, and one family member says, it's different, And then amongst the Latinos, if you have a visible primary caregiver who's the adult daughter, but it's really that oldest son, who is like, if you call it the fictive primary caregiver, it's a really different thing. And so I think that we all have challenges, and we create it in one community, and we have to gradually translate it and transform it for the other communities. So that was a statement more than a question. I may have to want to
Well,
respond.
I would like to elaborate on that. I totally agree with you, and probably California is our most ethnically diverse, although we're in Israel too. So in Israel, there are other family issues, but some of the issues relate specifically to the cultures. So and also to the degree of acculturation in our culture, and sometimes there are generational stresses around that. So my father and lots of Spanish, wasn't Spanish, but lots of Spanish people who were immigrants believe that it is their daughter's duty to take care of the parents. And yet, and there's lots of literature which I think is wrong, that Latina daughters think it's their duty, and so they do it with less stress. But in fact, if they're living in this country and have a different understanding from the culture of the United States of what it means to be a woman, and not just a caregiver, but also live your own life, then the strains between the generations can be huge. And so there's not only the culture of the culture from which the family comes, but the conflict between that and the culture that they live in now.
I totally agree with your point, but would also like to add that even within one race or ethnic group, there's tremendous heterogeneity, and we build into the skills to care training in terms of how to walk into the home and very quickly assess what are the underlying values of this home. Because any recommendations that we make or strategies that do not fit the preferred approach or religious tenets in some way, or address what the real values and goals are of that family will not really be implemented in a way. So I just wanted to add that point to your point. And I think that your point also raises the issue about funding, because they have these, in an efficacy trial, you have very strict inclusion criteria, and then you do need to modify it, and that does take some funding and testing. So that I do think that there's a funding of, for translational research that's still is very, very important.
Sir.
Yeah, I work within the VA, and we've tried to take some interventions nationally to the VA, and as has the Reach VA and STAR. And one of the things that the large healthcare agencies like the VA, one of the pushbacks I think has been about expanding the interventions beyond Alzheimer's, so that they're generalizable to other caregivers, other older traumatic brain injury, for example, or other older frail veterans and their caregivers. Can you speak to that tension in your interventions?
Do you want me to start? Well, we've been thinking about this in terms of, are there generic components, lessons learned over the, again, this wonderful, rich 30 years of caregiver interventions, which have mostly focused on dementia, but are there not these core, I'm going to use the word competencies, that families need? Mm-hmm. And then are there specific things that families need? And so, I think that I think we could develop a core, caregiver support skills, piece that could go across any diagnosis. However, I do think it then has to be, there has to be units specific to the disease process, because families have, whether it's TBI or stroke, cancer, which is a neglected, group of caregivers, or dementia. So that's how I've begun to think about it. So I've certainly learned from Skills to Care and other interventions, there are core issues: care coordination, taking care of yourself, problem solving, accessing resources, involving others, creating a strong social support network, and then disease specific. For dementia, how do you manage, wandering and repetitive questioning because, it's driving you nuts? For TBI, it's like, my husband's not going to work and I can't get him out of bed, those kinds of things. So that's how I've been thinking about it.
Yeah, well, I agree with you, and people have asked me that about the intervention that I've been privileged to work with, and I think everything Laura said is true, and I think that in order to really say that these interventions will work in other disease entities, we need to have funding to study them in those other disease entities. The issues are very different, and one thing that I've been thinking about is the older adults caring for people with mental illness, and worrying about who's going to do that when I'm not around to do it anymore. And for that, I think family involvement is key. But I don't know that it's going to work in the same way, and I think it's also essential to have the disease-specific parts. But, all of that, going back to something I said before, nobody has Alzheimer's disease in a vacuum.
Right.
So in a way, we're artificially compartmentalizing.
Great point.
Older adults have lots of diseases, and so while you're managing the Alzheimer's disease, you're managing the fact that maybe he has diabetes, and you have to make sure he has a shot before every meal, and in addition to that, he has arthritis, and if you don't move regularly, then you become rigid, and so in a way, there are some basic principles that you have to involve other disease entities.
Since you're from the VA, you realize REACH is flexible. It's already been translated into TBI, REACH TBI, and spinal cord injury, I believe. But I also want to bring out that the other program that I mentioned, Cleveland Managed Care, is incredibly flexible. It applies across all chronic illnesses. We adapted it for Alzheimer's, so going back that way.
So, I have a sort of wonky question.
We would expect no less.
We have a lot of really good family caregiver interventions, good outcomes, a number of different interventions. So if you back up from where we are right in this meeting, and you think about funders and policy question, should we have a comparative effectiveness research, a head-to-head comparison of Savvy Caregiver and the NYU Caregiver Intervention? That's one question. And I'm not asking that specific question, but comparative effectiveness is one of the things that I've heard said in this context. Another way of putting this is, should we try to figure out who needs what out of these interventions, and if so, how should we do that? So as we put together results of the meeting, which are to say what's needed, should anything in that area be raised?
Yeah, I would love to do that kind of a study, and I think that what we would find if we did a study in which we compared all of the evidence-based interventions in a rational way with a large enough study population is that we would learn that RDAT is better for this kind of person, and we would be able to have a profile. I would love to live long enough to do that study, so that the NYU caregiver, or the NYU caregiver intervention is best in this stage and best supplemented by RDAT for these people, so that an agency which would like to have a menu, ideally, would know if I walk in the door and they did a good assessment of me, that what would be the thing that would serve me and my family best. I think that's an essential next step in research.
Let me just add one thing on there. I think one thing that Mary said is key. I agree with what she said, and I want to bring in what Laura said earlier about the standard of care. I think a standardized, some kind of assessment needs to be formulated so that we can and provide agencies with some, to be able to make an informed choice when they look at the menu of services that you just mentioned.